Well, welcome everybody to Optometric Education Consultants National Webinar Series, Sunday night edition. It's my great honor and pleasure to introduce my partner, colleague, and friend, Dr. Greg Caldwell. He's a graduate of Pennsylvania College of Optometry, where he also completed a one-year residency in primary care and ocular disease. He's also a fellow of the American Academy of Optometry, a diplomat of the American Board of Optometry, and a fellow of the Optometric Glaucoma Society. He currently works in Duncanville and Johnstown, PA, as an ocular disease consultant. His primary focus is diagnosis and management of anterior and posterior segment disease, and he's been a participant in multiple FDA investigations. He's lectured extensively throughout the country and worldwide. He served as the president of the Pennsylvania Optometric Association and served on the AOA Board of Trustees from 2013 through 2016. He's got a servant's heart and an educator's mind. He has served the profession both politically and educationally. It's going to be a tremendous talk tonight. Herpes, ocular pharmacology, and pearls for the eye care provider. So let's give a nice virtual round of applause to my friend, partner, and colleague, Dr. Greg Caldwell.
Thanks, Joe, and appreciate the nice introduction and the friendship right back at you. So we're going to talk about some herpes tonight here, guys, and hopefully I like to give a lot of pearls whenever we do this and talk about some of the pharmacology. Here are my disclosures. The biggest bullet points on here are that it was independently prepared by me. You can see I've lectured from Alcon all the way down to Hero. You can see Allergan to Inova for ad boards. I sit as the PA medical director for Involve, which is a managed Medicaid. I sit as a chairman of the advisory for diabetes for a healthcare registry. You can see here that really the biggest points is that I have no financial or proprietary interest in any of the companies or products or service that I mentioned. And more importantly, if I do mention a product, I'm just presenting it because we have to talk about it. I'm without commercial bias. I'm not claiming superiority or any commercial products. And I think everyone has figured out that Joe and I are the owners of Optometric Education Consultants. When it comes to ocular herpes or herpes eye disease and oral medications, I think a lot of us feel that, when we're going to hear these lectures that we're just going to talk about Valtrex, acyclovir, and Famvir. We will touch on a few of these other medications here, Neurontin and Lyrica and doxycycline and L-lysine as an amino acid and the tricyclic antidepressants. That's mainly getting down, when we start getting into the post-herpetic neuralgia, we're starting to get the neurotrophic keratitis using maybe doxycycline. L-lysine is an amino acid that is used for to help boost the immune system for some people that want to go maybe a natural way to try and avoid the reoccurrence. And then the tricyclic antidepressants, again, going back to that neuropathic pain. So polling question number one here is, how many herpes viruses affect the eye? Is it 2? Let me help launch this here. Is it 2, 3, 5, 8, 10, or you don't know, and that's why I'm here. So is there a handout to download? Tracy,
I'm working on that right now.
I can help send it too.
I can do it.
And then Tracy, it should have been in the 645 email, but Joe's going to put it in the chat box there for you. There was a link for the handout email. Oh, thanks, Suzanne. All right, let's see what's rolled in here. Going to end this chat. We got a nice participation. Thank you, everyone. I'll share it. So we see here we have 2. We have 3. We have 2 as the winner, 3, 5, and 8, and then we have 10. And then we have I don't know, which is why we're here tonight. So, okay, I'm going to stop sharing. Let's get that out of the way. And let me get poll number 2 ready. And let's just do some fun facts about herpes. With regarding herpes, it's the leading cause of human viral disease. Now, I didn't really factor in a pandemic and COVID here, so it is only second to influenza and cold viruses. Now, there are more than 130 herpes viruses that have identified, and how I ended up getting to that statistic, and it could be more that have been identified by now. But if someone came up to me one time at a meeting and said, "Hey, my dog gets herpes. Can I get it as a human?" I really didn't know. I started looking, and you can see here that one of those dog herpes fell within the 130. But of these 130, 8 of them infect humans that are out there. And of that, 5 infect the eye. So that would be herpes 1 and 2, the zoster virus, and then the 2 that sometimes maybe we forget are in this herpes virus or Epstein-Barr and cytomegalovirus. Now, everyone out there that's seeing patients, I would bet you that you would test seropositive for the herpes antibody somewhere along the line. You got infected, because 25% of the U.S. population is seropositive by age 4. Nearly 100% are seropositive by age 60. And that's just going with general population. There's probably, we all remember now COVID has helped out, but I can remember, someone coming in, I'm in their exam room with them, they're hacking, they're coughing, they're sick, and they're going, "Yeah, I probably should have stayed home." And I'm like, "Yeah, you probably should have." I travel enough and so on and so forth that, I built up a pretty good immune system in seeing patients, but, next week my staff will probably be out because of that. So thank you very much. But point being is that you've probably been exposed to it. And if you would get your antibodies tested, you'd probably test seropositive. This is just another slide here reminding us that there are 8, sometimes 9. Sometimes they differentiate, this herpes, this human herpes virus, 6 and 7, they split it. So you can, there's 8 or 9, depending on which way, but 8 affect the humans. But when it comes to the eye, we're all familiar, I think, with herpes simplex 1 and 2, the cold sore virus. That basically comes out onto our eyes, a dendrite. Then we got zoster, Epstein-Barr, and the cytomegalovirus that is usually affected when you have an immunodeficiency that's out there. So this is, I thought, was pretty neat, is, in putting the lecture together, is looking at these 8. If we go over to 1, 2, 3, 4, 5, the 5th column here, you can see now why these come in a certain pattern, because once these viruses enter our body and they become part of us, the herpes simplex 1 and 2 and the zoster virus hang out in the neurons. They're neuronal. And we can see that the Epstein-Barr virus hangs out in the B lymphocytes, and the cytomegalovirus hangs out in the monocytes, lymphocytes, and possibly some other cells. So that's why we typically see the immunocompromised patient with the CMV, we'll see that kind of vitritis because it's coming in through the blood cells, but we see the dendritic patterns with the zoster and simplex because they're hanging out in into the electricity part or the neurons of the body. So this is going to be important a little bit later. So when you see this dendrite, the question I have is, is it, what happened there? Let's relaunch that. Relaunch poll. Relaunch. All right. So when you see this, is this infectious, inflammatory, or you don't know, and that's why you're here. When you see this dendritic type of infection here, and it's, I just want to point out this as we go forward, because when we get to talking about the herpetic eye disease study 1 and 2, adding steroids, not to add steroids, it becomes, pretty important.
Oh, and for anybody who is having difficulty, if you left click on the poll, you can drag it out of the way so you can see the clinical picture.
All right, so looks like majority of people are rolling in here. Okay, so I'm gonna end the poll, share the results, and I agree with the majority here is that this is infectious at this point, the way it's in a sense plowing through. And we'll talk about when it becomes inflammatory here as we go through the talk. So herpes simplex virus that we want to talk about, it's what I see the most. We do see some zoster that comes into the practice. It is the leading cause of cornea blindness in the United States. And I think that's a pretty powerful statement, is that, it's the leading cause of cornea vision loss, cornea blindness in the United States, primarily due to herpes simplex 1 to 65% of the time. I didn't say, third world countries or underdeveloped countries, that's the United States. So, we talk about the retina. What's the number one condition affecting that? This is the number one condition causing vision loss is herpes simplex virus. When it comes down to the nomenclature of this, we have infectious epithelial keratitis. It's not really critical to know whether it's herpes simplex 1 or 2. It doesn't give you a clinical advantage. You could culture it, send it to the lab, so on and so forth, but basically you're going to treat them both the same way. Both of them are easily beat up by the pharmaceuticals that we have available to us. So no really reason to know whether it's herpes 1 or 2 when it comes to that. Then you get the stromal keratitis, the endotheliitis, and then the neurotrophic keratopathy that comes along with it, which is one of the serious complications that occur with this condition. So need to recognize it. And we have a few ways that we can treat it out there, which we'll talk about as we go through the presentation. So this always seemed to be a big issue. We know that herpes 1 was above the belt and herpes 2 was below the belt, herpes number 2 being genital in a way. But whenever they culture, it's pretty much all over the body now. So really to know whether it's herpes 1 or 2 above the belt, below the belt, we do know that that herpes 2 does affect the eye. But again, there's no clinical relevance in knowing that because they respond to medications like I have up on the screen here now, Zirgan or Valtrex or any of the orals. So this here reminds me, there's 2 medications that I ask my local pharmacist to keep in stock for me at all times. I have this right down the street, locally owned, not commercial, friend, kind of like a private practice optometrist, private practice pharmacist, friend of mine. And I just said to him, I said, look, can you just keep 2 medications in stock for me? And one of them is 1% atropine, because when I have a patient comes in with an iritis and lots of pain, I like to be able to get atropine on board pretty quickly. And then the other one is Zirgan to have on board. Just for the fact, like in this case, you could see here, it's right over the pupil. And we're going to kill this bug, and we're going to kill it pretty quickly. But the quicker that we can get that bug killed without, causing any more epithelial disruption, the better off we are. So one of the clinical pearls with this slide is to, work with your local pharmacist. When the patient comes in, I always send it where they want to go. But if they say, look, I can get it in 24 or 48 hours, or come right over, blah, blah, blah. I just say to the patient, look, I know this pharmacy right down the road from my office here keeps this in stock. So can you mind me sending it to there? So, but you're going to see when I get towards the end here, you can go orals only on this. You can do an amniotic membrane if you have trouble getting Zirgan or Viroptic. Now, between the two, and I think I have a slide coming up here, Zirgan is a little bit more effective, or a lot more effective, and it's less toxic on the cornea. Viroptic, 8-9 times a day can really tear up the cornea. I've actually had people thinking, they sent them to me saying, Greg, I just can't get this to clear up. They get this wound that the cornea is trying to heal, and it's pseudodendritic, and it's just a toxic keratitis, just kind of stop everything. and they just put some on non-preserved artificial tears or just some tears on there and just let that cornea heal after being beat up. So Zirgan's the way to go if you could get it covered by insurance, so on and so forth. But you can go orals only in some of these, but I only do that if it's in the periphery. That's just kind of my clinical pearl. I'm sure you can get away with it centrally, but anytime this central cornea is involved, I like to do something if I can't get topicals, right? Again, I can't get this within 20 or 48 hours. I'm definitely going to start orals. And then if I'm going to do something because it's centrally active, I'll usually do an amniotic membrane on these patients. So with
Greg,
it, yes.
Okay, well, okay, we can launch the poll. If you want me to launch the poll, I'll
No,
do
go
that
ahead.
for you.
Yeah.
And then we can do a question. So launching poll 3.
Okay.
Have you ever used an amniotic membrane? Greg, a question came into the chat room. Cost and availability for Zirgan, highly problematic. Valtrex TID for 10 days works well in James's experience. You want to comment? Then I'll comment, Greg.
Yeah, I agree. Zirgan is sometimes costly. You can resort to. That's where I was going. Maybe it came in whenever before I got to mention is that, since this is the leading cause of cornea vision loss, anytime it's centrally activated or involving the central cornea, I have treated a lot of these with orals only, adding the steroid once we see reversal, which we'll talk about when we get to that part. But if it's centrally acting, I just don't like doing it alone. That's just my personal experience. This is a big dendrite right here over this pupil. I would probably, if I couldn't get Zirgan, I'd probably try and get an amniotic membrane to cover that. Go ahead, Joe. I think you were going to have a comment too.
Yeah, I have been seeing a lot of spider bites, so to speak, or herpes. I've had days where I've had Zoster and Simplex come in simultaneously, and with the dendritic ulcers where you have a true infection, the only time I've been using the Zirgan recently is I found some samples that mysteriously appeared in my sample case. So I've been using the Valtrex a gram 3 times a day with dendritic keratitis, and it has been very effective. Now I can understand the worry about central location, but one thing I don't always do because I don't think to do it, but I've done it before, is remember that before we had any antivirals that were readily available, 75% of these lesions were cured by actually debridement. And I don't mean scrubbing the cornea off, but I mean rolling gently, a gentle rub, removing virus. So I am not hesitant to do that if I remember to do that. A study came out, compared that with trifluridine and saw no benefit. But I do think there might be a benefit to reducing some of the viral load in those patients if you're so inclined.
Thanks, Joe. And I ended the poll and I started to share it here, and we can see here that the majority have not used amniotic membranes. A few have used dehydrated, a few have used cryo preserved, and a little bit of a mix here. But some people said I didn't realize, and maybe I will as we do the talk here, the next one that they see. So
Right,
herpes.
Before you go too long, there is a really good question here. Can herpes simplex and herpes zoster both cause these typical dendrites?
Well, the answer is yes, because they come through the corneal nerves. So the simplex is a kind of the classic dendrite, obviously no pattern defect. And then you can get the herpes zoster, which is usually the pattern defect. It's usually a more geographic type of lesion by the time I see it. And it has a little bit more surrounding type of edema. So I guess it's a little bit more cornea involved, if you want to say, as opposed to herpes simplex kind of be that classic dendrite. But remember, they're neuronal viruses, so they get into the eye neuronally.
Yeah,
Joe, any comments?
yeah, I've always found Simplex to be more classic. I mean, when you see it, you're really pretty sure of it, but Zoster is more a pseudodendrite, and you're just not quite that sure. And you think you might be looking at an obscure form of Simplex, and it can actually be Zoster.
And one of
I
the
see it's
less,
more pseudodendritic.
and one of the best ways to do that, well, I'm going to show a video coming up here, is, do cornea sensitivity testing on those, because they can be sometimes fooling when you're looking at them.
Couple more questions, Greg. What about lesions on the conj? I don't generally see them.
Yeah, that's a good question. I really don't see them that often either. The cornea is more innervated than the conjunctiva. I think it's 100 times more innervated, some number like that. So I never really have a classic, conjunctival lesion that I can take a picture of.
And Greg, what is the dosage of that you use of Valtrex 3 times a day?
1,000.
Yeah,
Yeah.
I agree. Same thing.
Yeah. And I'll get to that part, some people get, academic on it. They'll go, well, Simplex is a weaker virus, go 500 milligrams 3 times a day. If it's Zoster, go 1,000. When you get to these medications, they're super, super safe. So I try and keep things simple. If they do have Simplex, they're probably getting cold sores or something along that line. So I give them the largest amount, 1,000 milligrams 3 times a day, just to reduce that viral load. All right, I'm going to stop sharing the poll here, because people on smaller devices, that might mess them up. All right, so herpes simplex, virus. It's infectious when it's stromal. It's inflammatory, and it's inflammatory when you get down to the endotheliitis, and then you have the neurotrophic keratopathy. Neurotrophic keratopathy is a severe condition. But even in these earlier, in a sense, stages, if you want to say earlier, the infectious and stromal, going with a Cryo Preserve, and the only one in that market is the Procare, is a good option here. And there's a reason why I asked dehydrated and Cryo Preserved. I do a lecture on amniotic membranes. They are different, despite what the representatives out there want to tell you. And really, I'm a big advocate of, when you guys hear me lecture, just picking, if you're using something, you probably should read the package insert. And you can see here, this is nothing more than a package insert scanned, and I probably should get a better one here, but I don't have that many dehydrated in my office. But you can see bio-optics here. And if you come down to where it says general usage, I have it blown up right here. It says Bio-D is intended for wound covering. Procare is wound healing. This says wound covering. And if you just go up here, and if you just follow what number 2 says here, it says right here, complications should not be, it says complications, comma, Bio-D should not be used in the presence of an active infection. So, and that's really on all of the dehydrated membranes. The package insert clearly says, do not use in the presence of an active infection. And when you have that dendrite on the cornea, that's an active infection. If you have a central corneal ulcer from a contact lens wearer, and it's an infectious keratitis, I agree you could use an amniotic membrane, but probably not the best to be using dehydrated, especially when the package insert says, should not be used in the presence of an active infection. Now, when you go over to the Cryo Preserve, it says it is intended for, eyes used in the ocular surface, damage, stromal, inflammation, scarring. And it is a Band-Aid. It's more of a wound healing rather than wound covering. And that's even now recently how I believe Medicare has separated them out. One is wound covering, one is wound healing. And now it becomes indicated to be able to use a Cryo Preserved. So it's just, just be caution out there, when you're treating these. Joe has done a lot more, but I also get asked to be expert witness, and I'll always defend the heck out of everyone, but I'm not sure how hard it is or easy it is. Joe, you're more in the expert. If it says on the package insert, contraindicated, what does, you do jurisprudence and medical errors, what's your thoughts on that?
Well, if it truly says contraindicated, most people wouldn't do it. And standard of care is what would most people do? If it says contraindicated, that's a problem. If there is a label indication and you use something off label, that's generally not a problem if other people would do it. But what it comes down to is how savvy is a malpractice attorney, and can she or he find this? Sometimes they'll find things in our state statutes. Sometimes they'll find product inserts. Generally, I would say the attorneys are not that sophisticated to look at the product.
So, the key is be aware that it's there, do what's in your comfort level. I just like to point these out as we go through and do the presentations. So is education. So here was a good one here. A 51-year-old man referred for an amniotic membrane, Procare membrane. And basically we used Ziragan 5 times a day for 2 weeks. We added Valtrex. And at this point, he's pretty neurotrophic. And we needed to add something to this cornea to help him out. And we were able to help this person out by using an amniotic membrane. That was before we had Oxidate. We'll talk about Oxidate here at the end. So that was way before that one came out. Was now I would consider still a Procare, because it takes quite a few weeks to get Oxidate. You have to go through the process. So I would still use a Procare on that patient, but maybe add Oxidate to help with that. So that was just a little caution out there with regarding amniotic membranes. Now, when it comes to, the varicella zoster virus, we talked a little bit about Simplex. That's that, again, remember that herpes human virus number 3 of those 8 and of the 5 that affect the eye. This is number 3. And you could see here that it follows, the pattern of the trigeminal nerve. We have the ophthalmic division, we have the maxillary and the mandibular. It's really the ophthalmic division that that will affect the eye. You can get maxillary, but it basically just affects the eyelid. If it's the maxillary division, you'll see the lower eyelid maybe swell. But really, the globe is, in a sense, protected based on the way the trigeminal nerve runs through the skull and innervates the eye. So this is one of my favorite cases here. This is whenever we want to see these come in. This patient came in, and I've learned over the years to kind of be more osteopathic, I guess, when it comes to this, more hands-on, trying to, help get to the root cause of diagnosis. I guess my binky, my slit lamp was what really was my go-to. Like when patients come in and they had red eyes, my protection, my super tool, human tool, was to get them behind the microscope and start looking. But when this patient came in, she just said, yeah, my eyelid's a little bit puffed up here. It's a little bit red. It's a little bit inflamed. And, I wanted to feel around. She said, ouch on one side, maybe not so much on the other. And you could see right here, she had a lesion. It had to pull, her hair back a little bit. And you can see the lesion is right here. But I thought this was pretty awesome right here when I saw this. This almost looks like that dendrite that's coming out on the cornea. And this really gave it away what was happening with her. You could see the swelling that was occurring. She was getting some edema down here. Her eyes a little bit red. There's no dendrite on it, but she's got herpes zoster. And really, this is one of the best times to diagnose and treat. It helps with the post-herpetic neuralgia. It helps with getting the instead of that virus erupting, you're starting to calm the virus down. You're going to assist the immune system in treating this patient. So this was one of my favorite pictures right here, because you can just see it just almost looks like a dendrite. You can see how it's following that neuronal pattern. And this was zoster. And there's different stages, as you guys know. You've seen these patients come in. This patient has probably had this now for a couple 10 days, 2 weeks. You can see the scarring that's going on. You can see the lesions that are occurring here to this person. And then typically when you have the end of the nose involved, you can see that the globe's involved, and that takes a little bit more of a examination with the patient just to make sure everything's okay. Now, have you ever had this happen to you where a primary care doctor sends you over any of these people? They're already, looking like this. They have the ophthalmic division involved. They've already maybe put them on some oral steroids along with, the Valtrex, 1,000 milligrams 3 times a day. And they send it to your office, and maybe it's even this patient, and you go, hey, yeah, I mean, you have Zoster, and your primary care doctor's already put you on, Valtrex and some oral steroids, and what am I supposed to do here? And the reason being is I've chatted with, primary care docs, what's going on is when they went to school, they were taught that Zoster can affect the eye with an episcleritis, scleritis, a keratitis, iris atrophy, glaucoma, vitritis, retinitis, choroiditis, optic neuritis, and even cranial nerve palsies. So even though they were diagnosed properly and they were treated properly, what they want is, basically make sure, since they know that the cornea become involved, inflammation in the eye with iritis and keratitis, and then a retinitis, and then even palsies can occur. They just want a good ocular exam, making sure maybe you don't have to add Zirgan or anything topical to that cornea, and then a report back. So I get that a lot of times when doing this talk, like, why do PCPs always send this to me whenever they're properly diagnosed and treated? This is the reason why, because when they go to school and the PAs, the physician assistants that are doing a lot of the work out there, they know that it can happen, and they should get a good eye exam and make sure that we report back to them.
Greg, I had 2 patients like that within the last 2 weeks. One patient was really anxious about the fact there was a lesion that was getting kind of close to her eye, and was really worried that it was progressing on. And there's no ocular involvement at all. And she was being properly treated. And I explained the proximity to the lid or the eye was not my concern. I talked about the nose. And the fact that she's already on, it's not like a progressive creeping disease that it's going to, you're being treated well, and they just want that blessing. Now, the other patient was a 47-year-old who had the orbital pain, no lesions at all. She had vision loss and was given a script for oral prednisone and Valtrex, and it was actually optic neuritis, and I ended up diagnosing her with MS.
There you go. As that was, you were doing that talk, a couple of the questions rolled in here. I don't have much experience with Regenerize. I believe that it's basically an amniotic membrane that's kind of been chopped up, put into a bottle. Joe, do you have any experience with that?
I do not.
Yeah. Something I probably should meet with one of the MSLs of the company and talk about it. I think it would be good, maybe from what I know about it, and maybe I could be wrong, is that I'm not sure if I would want to maybe use it on something centrally cornea activated. I think it's great for dry eyes and other keratitis from what I've heard. But something I'll definitely have to dig into. So really, I don't have any opinion on it. Other than maybe not an infectious keratitis. And then, is it best to stock hydrated versus dehydrated? Cost, shelf? Yeah, the Cryo Preserved, which in this comment here would be in a sense hydrated. Cryo Preserved would be a little bit more costly. But then when it comes down to shelf life, I hear that all the time from the reps out there. Oh, mine's good for 3 years. I think one is a Cryo Preserved is good for 2 years. So, if you're buying something in your office, hopefully it's not going to be sitting in there for 2 years. I do buy 8 of these at a time in my office, the Cryo Preserved. I keep them in the freezer. you can't predict what's going to come in, but it's nice to have them there. And usually when I hit around 1 or 2, I just put another order of 8 in. But, sometimes I burn through them in 2 months, and sometimes it takes 6 or 8 months to go through them. But the cost is going to be a little bit more, but they are not equal. Wound covering versus wound healing, and a few of the biologics are preserved in a cryopreserved. The 2 would be Pentraxin 3 is one that you want to look up. That's preserved, that is lost in a dehydrated, and heavy chain hyaluronic acid, which is truly anti-inflammatory. All right, Joe. Well, thanks for launching the poll. And is this a herpes corneal lesion? I know it's kind of no history, nothing out there, just kind of looking at it. Looks like we've got them rolling in here nicely, getting some yeses, getting some nos, but a lot of I don't know. And I agree with that because I really didn't give you any history, but you can see I have some fluorescein in the eye. And this is what Joe was talking about here. This is how some of these Zosters come in. And, it looked like it was pseudodendritic, and maybe there was a lid lesion and maybe not. And, it looked herpetic. Could I tell herpetic versus simplex versus zoster? But what is one way that we can, help figure out what's going on here? And Oxidate has really helped us out with that. And that's by doing cornea sensitivity. I've done cornea sensitivity for quite a few years on some of these cases, just to say, okay, you're neurotrophic, but we really didn't have much treatment out there. So there's a few ways. There's a Cochet-Bonnet type of instrument out there that they use in studies, but there's different ways to use and test cornea sensitivity. I've heard some docs using, they take a suture in a surgical practice, and they'll cut it up and they'll grab it with a forceps and touch the eye, a sterile suture. I've heard people taking, dental floss, not wax dental floss, using that. I pretty much just take a cotton tip applicator, take it right out of the bag, basically just grab the tip with my fingernails, pull it off, and kind of wisp and kind of hold it up and just see if I have a fiber. And that's what I did here. And you're going to see, hopefully this video will play. This is me doing cornea sensitivity on that patient. Now, that lesion that I showed you was on the patient's left eye. This is the patient's right eye. Watch what happens. Boom, blink, boom. Quick blink. You can even see that it maybe even made a little mark on the cornea. Here's that lesion right here. This eye is not numb. This is just fluorescein in the eye. And you can see that I just laid this right on there and drug it right across. This eye is not anesthetized at all. That's just sodium fluorescein that's in there. Let me show you again. Watch what happens as soon as I just get this really, really close. As soon as I touch, boom, blink, boom, blink. Come over here. The patient blinks a little bit here, just I think because I'm coming close to them. But you can see it's laying right on that cornea, and you can just drag it right across the patient. And I said to the patient, "You didn't feel that?" "No, I didn't feel that."
And be careful about the eyelashes, because that will give you a false positive.
You mean bumping them?
Yeah.
Yeah. Be careful bumping them. Yep. All right, we've seen that enough. So let's go through a case here. I'm going to stop sharing the poll, and we'll get poll number 5 ready. And this is a 37-year-old woman. The eye is red and painful. The left eye or the right eye has a little bit decreased acuity, and you can see the refraction and externals are pretty much normal, really non-contributory to the case. So basically, right eye is red and painful. And we can see here that we have a classic dendritic, most likely herpes simplex type 1, type 2, doesn't matter. So that's the slit lamp, diagnosis would be a herpes simplex. We have, what I like to find out is when the patient comes in, have you ever told you had this? Is this your first episode, second episode, third episode? Because the herpetic eye disease study allows us to be able to, in these recurrent infections, the study used 400 milligrams twice a day of acyclovir. I would just do 500 milligrams of Valtrex in this case. But what I'm trying to find out is, is this something that's recurrent, or is this the patient's first episode when they come in? Like, yeah, I've been bounced around, or every time I get these, I'm always out of town, or whatever, just trying to figure out first episode. So what would be your treatment for this? When it comes to treatment, Zirgan, artificial tears, steroid, always, sometimes, never use a steroid. Well, what it comes down to here is, when you have the active infection like this, we don't want to be using a steroid. But we do want to add a steroid whenever we start seeing reversal. I'll see these patients maybe the next day or in 36 hours to see how things are going. But what I'll do is, especially since this is kind of now, this one here is more centrally involved, maybe inferior central, but we start getting over that pupil where we can start getting that cornea vision loss. I definitely want to add some anti-inflammatories onto this eye sooner rather than later on this. So what about orals at this time? Would we want to use orals? Yeah, I use orals on all these cases because they're so safe. I'm not considering them long-term at this time. This is the patient's first episode. I'll probably use orals along with the Zirgan. If I don't have access to Zirgan because of cost issues, so on and so forth, then maybe I would just do oral anti-herpetic at this time. Failure to respond to topical is another reason to consider using orals. But the orals have become really, really safe over the years. We did a lot of these topical, but we can see now more and more docs are just migrating over to doing just oral treatment with these. And we're basically just going to use it for a few days. No, we're not going to go long term on this patient. Now, here's a question. I guess I kind of turned it into a poll question. The patient comes back 4 weeks later, they look great, right? We just cleared up that lesion. We use, a Lotamax or a lotopredinol type of probably steroid. You could use, Predforte if you want, whatever it is. They're going to be on it for a short period of time. You've diagnosed it early. You use the anti-infectives. You use the anti-inflammatories. But what's the chance of this reoccurring in the next 12 months? And the answer is 25%. And that's why it's good to know the first episode, or at least the patient thinks it's their first episode. Because what is the drop that you just made them feel good with? You just made their eye feel good by adding a steroid, right? They came in, their eye was painful. You gave them some pills, you gave them some Zirgan, and their eye still felt pretty miserable. But it wasn't until you added that steroid that their eye started to make this nice turn. Well, patients keep this medication in their closet, and all of a sudden, 6 months down the road, when there's a 25% chance of this come back, they go, you know what? That's the one that made my eye feel good. And I just had a patient the other day. I should have added it to this lecture. Came in after doing that. They did the provocative test for me. They had 6 dendrites on their cornea. I got a nice, beautiful picture of it. But what I want to point out is that we always want to tell our patients that, listen, this virus is a part of you. It's a part of me. We all have it. It goes back to that opening slide that we talked about. By age 60, 100% will test seropositive. This lives in your neurons. For some reason, your immune system was weak. It allowed this to come out. I use this steroid to make you feel good. That's the last thing you want to do when you have the infection, is by using a steroid. So I try to press upon it at this 4-week visit, like, hey, things look great. I have an anterior segment camera. We show all the pictures. They feel good. But I'd like to press upon, please, if you get this, there's a 25% chance coming back. Please come in. Let me put the sodium fluorescein in and see what we can do for you. Now, as a cranium keeper here out there, I like to say that, how long should you use trifluoridine or Veroptic? 1 drop every 2 hours, up to 9 times a day. The package insert says you can use it up to 21 days, and you've eradicated like 98% of the virus. Between the two, Veroptic and Zirgan, Viroptic is more toxic. I've seen so many of these toxic keratitis coming in from Viroptic. I have a lot of optometrists that refer to me in the area, which is great, with a nice little compliment, and we work well together. Don't have to send to ophthalmology all the time. And whenever I see this, it's not really the virus, and sometimes it looks more of a pseudo-dendritic appearance. We just stop the Viroptic and just use some preserved tears or non-preserved tears, and we can get that cleared up. So Zergan's a little more gentle. 1 drop 5 times a day into the cornea clears, and then once you see, or to the ulcer reverses or closes, and then you can do 1 drop 3 times a day for 7 days. So it's between the two, when you do efficacy studies, the Zergan is definitely more efficacious than the Viroptic. They both work to kill the virus. Just one's a little bit more effective, and one is a little bit less toxic to the cornea. So we're still talking about this 37-year-old female. She comes in, first episode, you told her a 25% chance that it could come back. And there we go. 5 months later, she comes back. So what's our treatment for this patient? Treatment is going to be the same thing. We can do some orals. We can do some Zergan, some artificial tears. When do we add the steroid? I add the steroid when we get reversal of these lesions. It doesn't have to be 100% closed. We were taught that a lot in optometry school. My opinion is that once you start getting reversal, that's whenever you can add, a steroid. And then when you do that, I typically check them back almost 12 to 24 hours after adding that steroid, or if I'm traveling, have someone in the office do it. Now, what happens when it comes down to adding the orals? We could use full strength, right? We could say, I'm going to give you Zergan 5 times a day. I'm going to give you 1,000 milligrams of Valtrex 3 times a day for a week. But, what's the chance of this coming back now that this has happened with the second time within the same year? That's a 43% chance of this occurring again. And this is all coming from all the herpetic eye disease studies. The herpetic eye disease studies have told us 25% chance, 43% chance of it coming back after having that second episode. And if it's within the same year, within the same 12 months, that you can get that 43%. So again, we did the treatment, Zergan, started some orals. At this point, you say to the patient, hey, look, this is a 43% chance coming back. Why don't you go on, if you don't want this to come back again, there is an option that you can take acyclovir, as the herpetic eye disease study taught us, that you could take it 400 milligrams twice a day, or you can just take, Valtrex. A lot of times what will happen is the patients will say, hey, Doc, thank you very much. Thanks for being very knowledgeable in this area. I don't really want to start a medication on at this time. So that's typically what happens, but I would definitely bring it up, since the herpetic eye disease taught us that we can decrease these reoccurrences, and this is the leading cause of vision loss, cornea vision loss in the United States. Now, most people decline, and I should print it out and show you what I have typed. When I'm treating these, I already have it in my electronic health record, something that goes along, educated the patient on, 43% of this coming back. It's a leading cause of cornea vision loss in the United States. Went through the options, went through the treatments, risk benefits, patient declined. I just like having it in there that I discussed with the patient, because, there is a herpetic eye disease study too that says you can prevent these from reoccurring. So you can see here, it happened, the first time, patient came back, we healed it all up, and then she comes back, another time here, and, it's the same picture from before. I don't have the other picture, but you can see it's the first picture from the first time, but you get the point. Came back, third episode, going to treat the same way. Zergan, artificial tears, some steroid. And then what about the anti-herpetic? At this time is probably whenever we start seeing these happen, the patient says, okay, look, these are crazy. If you're saying you can stop these from occurring, this would be awesome. So what's the dosage short term? The dosage short term would be 1,000 milligrams of Valtrex 3 times a day. And then once I get them out a week or so and it's all healed up and we're getting reversal, then we would prescribe 500 milligrams once a day. If we're going to do that on this 3rd episode, I prescribe the 500 milligrams right off the bat and just tell them to take 2 for the first few days. And then we start, adjusting the medications as we go forward. So my clinical pearl would be, if you get to this point, you can write for, a 90-day supply of, or a 30-day supply of the Valtrex. You can write it however you want. A lot of times, I don't do 30 pills. I'll do like 90 pills, 180 pills right on the bottle, take 3 times a day. It's going to be for a month, so on and so forth. And then I just adjust the patient as they come in, just to help them out with that cost ratio of getting the medication. So with that being said, I have another question here, and I'll launch the poll here. It's my question is regarding like cornea dynamics. What is the flow of fluid through the cornea? Is it from front to back or back to front? And let me just clarify that is that when the epithelium is missing, okay? When the epithelium is missing, what's the flow of fluid through the cornea? Again, front to back or back to front? Anything come in the chat box, Joe?
Yeah, there's quite a few here. Do you recommend anything put on the forehead vesicles when we have herpes zoster? Once you've done the antivirals, is there anything that you recommend for the vesicular lesions?
Typically, I don't. I've heard that you can do, erythromycin ointment to kind of keep them moist and maybe stop a secondary infection. But I typically don't, do anything. Maybe if they have some triple antibiotic at home, if they ask anything that they can put on it, but typically I don't. Do you do anything?
I might, if they ask, I might recommend calamine lotion.
There you go.
How long would you use a steroid after the dendrites have resolved?
Yeah, that's going to be depending on how the cornea looks. In Simplex, and we're going to talk about that here. That's why we got this cornea dynamic flow going on here. But, I usually use the steroid until the infiltrate or the haze or the edema is gone. And then I'll probably wean them off something like, if they're using it QID, probably another 4 days after that. And then TID for 4 days, and then BID for 4 days, and once a day for 4 days. So, that's it. But I usually wait until the cornea is near 100% back to normal.
Do you ever recommend the shingles vaccine when it's zoster? Any benefit to that in a young patient after the first zoster ophthalmicus event?
Yeah, we recommend it. It's just whether or not you can get it. The Shingrix is the way to go nowadays, and we'll talk about when we get there. So you can recommend it, but obviously we don't give it as optometrists, at least not in Pennsylvania. I'm not sure if any states are able to do that yet, but we can certainly make the recommendation to the PCP. It's just then getting it approved and getting the patient. So yeah, we could recommend it for the patient.
Here's more of a comment, and I think it's a good comment. With multiple episodes of dendrites from HSV, risk of antivirals is very low if the kidneys are healthy, but the risk of corneal scarring is pretty high with multiple episodes. I think I would agree to that.
So is the comment to use
No,
orals?
I think that the suggested comment might be urging the patient for prophylactic therapy, because each time this happens, something could go wrong or could end up with a worse outcome.
Yeah, and that's our job, is to explain that risk versus benefit, right? So we want to make sure that we're clear to the patient that it's the leading cause, and that's why we open up with the comment is that this is the leading cause of vision loss. So yeah, we're all saying the same thing here. So we're all agreeing. Great comment. I appreciate it. And yes, that's our job, is to make sure, like, hey, you know, the medications are pretty safe. This might be something to at least hop on for 6 to 12 months. Let's at least allow maybe your body to catch up and maybe keep this virus at bay.
If you're using long-term suppressant therapy, what is the duration? 3 months, 6 months, 9 months, 12 months?
We're talking suppression, meaning probably like Valtrex 500 milligrams.
Yes.
So I actually probably, what was last year, to see if there was an update. I did not find an update. So there was the herpetic eye disease study, and obviously whenever people go into the study, it's not that they just go away. It's just that the study is not funded anymore. But every so often the doctors get together, and kind of like the ocular hypertensive treatment study, the doctors get together and they kind of talk about what's going on and try and look and then doing some analysis. And the only thing that I could find that was after the herpetic eye disease study number 2 was those doctors got together, and the statement was, after a year, we found benefit in using it in some patients. That was kind of like the summary. So I really haven't found anything out there. Joe, I know you do a lot of writing and read a lot of papers. Do you have anything to add to that?
No, I agree. It's kind of inconclusive.
Yeah.
Do you?
So
Okay,
I can
sorry,
tell
go
you
ahead.
what I do for those, though, is that I definitely keep them on for about 12 months. And then, and here's really my go-to, guys. Here's my clinical pearl. If the patient was an active cold sore sufferer before I saw them, right? So I see these people, or I have these people come in, you know, they say they get them in their nose, they get them on their lips, they're getting them all the time. They finally came out on their eye, it found the ophthalmic division. And I say, look, it's just like our attendee said, this can cause serious complications to your cornea. So I'm going to recommend you go on this. After a year, if they were kind of like herpetic sufferer, their immune system just couldn't keep this virus at bay, then if they're feeling okay and we're getting the kidneys checked, which we'll talk about that, then I would keep them on it. If after a year they really weren't herpetic sufferer getting all these cold sores, I say, okay, you've been pretty quiet. Let's get you off and see what happens. So that's kind of my go-to. That's kind of my clinical decision, because the studies were inconclusive what to do after that. So if they were herpetic sufferer and they're pretty quiet and pretty happy, then keep them on it.
Is there any kidney problems associated with long-term Valtrex?
Yep, and we're going to talk about that.
Okay.
So all of them have, they're all cleared through the kidneys. So anytime that you're going, then we're going to chat about that. But they're all cleared through the kidneys. They're not cleared through the liver. So anytime you're going long-term, you want to make sure you talk with the primary care doc, get kidney function tests, and then or at least let the doc know that they might want to get kidney function tests. Or they might say, go ahead, they'll start them and check the kidney function test a little bit later. But long-term, kidney with these.
Do you dilate every herpes patient at initial presentation to rule out a retinitis?
Do I dilate them? No. But do I take a look or maybe do an Optimap on them? Yes.
I myself generally don't. One does not beget the other. Chances are, if there's a retinitis, that's the presentation. Should Zergan Veroptic be tapered?
Should Zergan or Veroptic be tapered? Not really. So you have it's an anti-infective. So you're just trying to kill the Simplex or the Zoster. Once it's dead, it's dead. Now you just got to deal with the inflammation, which is what this question is about right here. So that's a good one. That might be a good little prelude into this slide. But are there any more questions?
Oh yeah, quite a few. In fact, we may end up just answering questions tonight.
Which is good.
From a former student of mine, do you ever refer to the PCP if the patient seems hesitant about orals?
The answer would be, I don't recall it happening. But the answer would be yes. I mean, I would, certainly if the patient wanted to get their primary care doc involved. But if you're going to do that, that's going to be a phone call over to the doc so that everyone is on the same page, because the primary care doc is not going to have the advantage of knowing what you saw underneath the microscope. So certainly the patient can do that. But I would then say the caveat would be you're going to have to call the primary care doctor.
And generally, my experience has been when you involve a PCP, the PCP usually responds to the patient something to the effect of, well, you should do what he wants you to do, or stop going to him, but don't waste his time.
Yeah.
Hold on, I got a few more questions in the chat. With Zoster skin lesions, do blood thinners have any effect to cause bleeding?
Boy, good question. I would say maybe a little, but if the patient would scratch them or pick at them and then open them up, they would probably bleed a little bit more. So I would say yes, but just to kind of spontaneously bleed without any, then I would probably say no. But Joe, any thoughts?
That's my thought as well. It doesn't go deep enough into the dermis to affect the capillaries generally. With corneal scarring from HSV affecting vision, do you see improvement with scarring over time on its own? Or if the scarring is significant, do you treat long-term with a steroid drop?
Yeah, if I'm starting to get scarring on a patient, I'll definitely use steroid, but I'll quickly revert to getting a Procare or a Cryo Preserved amniotic membrane on there. That has some regenerative properties on there, maybe even two. Put one on, get it on, see what happens, put the steroid on there, and then quickly, maybe within about a 2 to 4 week period, get another Cryo Preserve membrane on there to help with this person. And I mean, at this point, it's not infectious. If you feel that a dehydrated at that point has enough properties in it, you could go with a dehydrated. But I think if I'm getting cornea scarring involved, steroids and amniotic membranes are the way to go.
You know, what I explain to patients when we're dealing with herpes zoster and herpes simplex, I tell them that the virus, isn't a mutatable. It doesn't really form variants. It is very susceptible to the medications that we have. It's just once it gets in there, it causes a lot of collateral damage. And we can formulaically tell you how to treat this in terms of how many days, how many drops, how many milligrams, but the cleanup is highly variable. And it's like that rude party guest that walks into your place, drops a stink bomb, knocks over a candle and sets the carpet on fire, then overflows the toilet. You're going to get rid of him right away. He's going to be thrown out the door. But now you got the cleanup. I'm sure part of that cleanup, you're going to talk more about, additionally, amniotic membrane, oxidate, and probably vital tears. So I'm going to let you take over, Greg.
Yeah. So hold those questions there, Joe, because you just teed that up beautifully for me. So I'm going to stop sharing that. A lot of people said back to front, 56%. And this is what I want to show on this slide right here. This over here is a patient of mine that it was probably April-ish. It's now winter time. We do a lot of our work on our cars around here. So they're taking their tires off, doing brakes. And this guy is trying to pry, the cap off to get to the brakes, and the screwdriver, boom, up. That's basically a kind of a crappy LASIK flap in a sense, done with a screwdriver. And it bounced off and went up into his fornix. You can see here his pupils already not round, it's oval shaped, and he's got a little bit of a hyphema and some concheme, maybe even a conjunctival laceration over there. So my point is, oh boy, maybe we should go back to the questions. Or Joe, you're gonna have to fill in.
All right.
No, we're okay. We're okay.
Okay.
All right. So basically, Joe calls me and we put fluorescein in this eye, and you can see what's happening here is that the sodium fluorescein is being pulled into the stroma. My point here is that the epithelium is super, super important. The epithelium seals the front of the eye. And when you put sodium fluorescein in, so I put the sodium fluorescein in, and this was just minutes. But when you have a big laceration like this, you have the endothelial cells in the back of the cornea, which are keeping the cornea deturgescent. So the epithelium, so my analogy is, if I had a vacuum cleaner here in my hand and I turned it on, I'll be able to sit around here at my desk and suck up the dust and suck up some paper clips and so on and so forth. But if I put my hand over this vacuum cleaner hose opening, nothing can get in because my hand has sealed it. So you could see that, this picture, I love what's happening here in a sense, is that we put sodium fluorescein in, there's a crack in the epithelium, but you can see now how this has been pulled into the stroma. Now, why did I go through that big, long talk? And that's showing you that if I put sodium fluorescein in the eye, it's the fluid dynamics are from front to back because the endothelium is trying to keep it at deturgescent. Now, if there was no break in this epithelium, that would not be pulled into the stroma. Now, there's a big, long, drawn out reason why I told you that. You could see what's happening here with this dendrite. Now, think about what we're going to do here. We're going to put Zirgan on it. You're going to maybe not do Zirgan. Maybe you just do orals. My point is you're going to kill the bug. You're going to kill the virus. And then where is that virus going to go? Because the cornea is open, the epithelium is open, it gets pulled into the stroma. And when it gets pulled into the stroma, that's when you have the inflammatory reaction, right? So it's such a, the virus comes in through the corneal nerve, it's infecting, it's open up the epithelium. We recognize it as a dendritic pattern. We do a great job. Now we kill it. That's why when I see reversal, I try to get steroid on as soon as possible, because I know dead protein, dead bug, it's like roadkill on the side of the road. You see something that's hit an animal, if nothing comes along and cleans it up, it just goes through a natural decaying process. That dead protein, and we've learned that well through the COVID virus, right? Why did people, that before the vaccine was out, people would get it, it would linger. We have an adaptive immune system. Our body T cells would react to it. And then some people would have a heck of a cytokine storm and some people don't. Our body is reacting to that dead protein that our immune system has killed. So our immune system can kill this herpes simplex. We use Zirgan, we use Valtrex, but where does it go? It follows this pattern right here. It gets pulled into the stroma and you have the inflammatory reaction. So the herpetic eye disease study, and why I like talking about that, has taught us that there is a benefit from steroids and stromal keratitis. Well, think about what stromal keratitis is. It's inflammatory. So if it's inflammatory, steroids would work. There's no benefit from oral acyclovir in stromal keratitis. Well, stromal keratitis is inflammatory, so using an anti-infective doesn't help. It actually, there's the oral acyclovir is probably what caused the stromal keratitis because we killed the bug. And then there is a benefit if there's an iritis present. Now, the biggest thing that came out of the whole thing, and then right here you can see it says there's no benefit from acyclovir from stopping the progression to stromal or iridocyclitis. Again, it's probably because the Cornea Dynamics, you kill it with the acyclovir, it doesn't stop it from progressing to stromal iridocyclitis because it kills the bug and pulls it in. But the biggest thing that came out of it is this one right here, where you have 400 milligrams twice a day that decreases the reoccurrence by 1 year. And this sets us up to being able to use long-term maintenance. And then it also sets it up to make sure that we explain it to the patient when they come in that second time within 12 months, there's that 43% chance, and the cornea could have scarring, that makes sure we're telling the patient about recurrent, that we can help with the recurrence of this by putting them on a maintenance dose.
A couple more good questions came in. Does insurance cover Cryo Preserve, Procare, or other amniotic membranes?
Yes. Depends, I guess, on the insurance company, but I know Medicare covers them. And then usually if Medicare covers them, then the other insurance companies cover them. The issue that I run into from time to time is people have some large deductibles. They might have a $2,000 or $3,000 deductible, which that would go towards it. I don't spend people's money for them. I tell them what's going on. I didn't pick their insurance. I tell them this is the recommendation, and then they decide on what they want to do. But where it's not really usually an issue of coverage, it's usually an issue of a large deductible.
And could you discuss reversal signs more? How do we know the patient's getting better?
Yeah, I like taking my camera and taking pictures of these, and then as they're healing, it's just it's like on some of these patients, you see that it's kind of cruising along, and if we don't do anything, it's going to keep cruising along, and it's reversal. Could we just stopped it, or you stopped it and it's trying to heal, and those wounds are starting to close up a little bit.
My experience has been with simple dendritic ulcers, if you use an oral or a topical, and within a week or two, things are pretty well clear, except for maybe a little bit of stromal edema. That's good. You're doing well, but that may not be typical. Remember, after you've dismissed that rude guest, you still have the burned carpet and the overflow toilet to deal with, and that can take a lot of cleanup.
Yeah, it's these conditions is more or less with the way Joe is saying here is we can kill the infection pretty easy. We just have to deal with the inflammatory reaction afterwards. And the quicker we get in front of that inflammatory reaction, the better off we are. But the key is seeing that kind of in that sense, that reversal. You're seeing that that dendrite not progressing. It's no more new lesions, no new terminal end bulbs. They're starting to close up a little bit. That would be reversal, and that'd probably about day 3, day 4, you should have reversal, especially if you're using orals and topicals. Anything else?
Nope, we're clear.
Okay. So recurrent herpes, keratitis, topical antivirals, oral antivirals. Remember to check for what? We want to check for allergies. Everyone reacts. This patient was allergic. We're still on a 37-year-old patient. She's allergic to penicillin and Keflex, but now she says, "Oh, I'm also now pregnant 2 months." Now, what do we do for this patient? She's now added a layer to it of being pregnant. Is it safe? So before, doing any medications, we take a thorough medical history, which includes, chief complaint, history of the present illness. In this case, the review systems, we want to make sure we check out the kidney disease because these are cleared through the kidneys, any chance they're pregnant, if they have any adverse reactions. Now, back in the day, we used to have pregnancy categories A, B, C, D, and X. Most of them are falling into the category C because they really don't do studies on pregnant females with them. It's usually someone doesn't know they're pregnant, they're taking the medication, and that's how we get some outcome. But we do have patients that are in category A and B, C and D, X is bad. I can tell you right now, all the orals fall in the category B back in the day. But I also want to point out that this did change in 2014 was the final rule, didn't become effective in 2015, June 30th. And I just want to point out the package inserts. Package inserts have changed and so has the PDR. It used to be category A, B, C, D, and X. June 2030 of 2015, things changed after that. And you'll see now that there's pregnancy, lactation, and then anything with the male or female reproductive. And this is where you look on the package insert. So again, pregnancy is 8.1, lactation is 8.2, and then anything with the female or male reproductive system is 8.3. So this is just a newer, this is kind of a hybrid and this says pre-June 30th. What that means is that Valtrex was out before June 30th. And then this is the newer hybrid package insert. It says right here, Valtrex. If you get out here, it says the 8.1, 8.2. You can see they have something on pregnancy. It still says category B because it's the hybrid, and then it goes through and it gives the kind of the post June 30th of 2015. So you can see here, there's 8.1, there's no 8.2, but it does talk about nursing mothers under 8.3. And just to kind of show you, this is just a Xiidra that was after June 30th. It came out much later. And you can see if you jump down to 8.1, there's 6, where is it? Right here, pregnancy. You could see that they didn't go with the pre-June 30th of any category A, B, or C. It just starts talking about 8.1, 8.2, and there was nothing on 8.3. As someone pointed out a little bit earlier, these are cleared through the kidneys. So you want to, identify patients on hemodialysis. If they are having kidney issues, it's not that they're contraindicated. You just work with the PCP. You have to make a phone call, and they'll adjust the dose based on the patient's creatinine clearance. So, you just have to be aware that can cause it. And you also have to make sure that, if the patient does have any kidney issues, just to work with the internist or the primary care doc. So oral antivirals in the first generation that were out many years ago, they got a bad rap. And I think that's why maybe still to this day, people are like, maybe out there, like maybe they remember that. And that was mutagenic. It caused the genes to mutate and maybe create cancer. These are the third generation, and these work really, really cool. As you know, if you take something, a virus, it goes into every cell of the body. You take a medication, it goes into every cell of the body. And what happens is these are prodrugs. So when the drug goes into a cell that doesn't have the virus, the cell is metabolically active. It just burns away because of the metabolic activity. However, if the virus is hanging out in that cell, the virus produces an enzyme. That enzyme goes and cleaves part of that Valtrex, that third generation Famvir or acyclovir, causes it to activate, and then it kills the virus. So it's a really, really cool how the pharmacist really figured this one out. Is then again, it goes into the cell. It doesn't become activated if there's no virus in it, but it gets activated in the cell by the enzyme from the virus, activates it, and it goes and kills the bug. Really, really cool. It could be used prophylactically if patients want to have PTK, LASIK, PRK, a full penetrating keratoplasty. Sometimes a patient has so many scarring from these conditions and they have to go for a corneal transplant, they'll use it prophylactically before the surgery. All right. So your go-to oral antiviral. So just what's your go-to oral antiviral? Is it acyclovir, Famvir? I don't have one. That's why I'm here. Is it Valtrex?
Comment, Greg. I heard there's no benefit to using an oral and a topical to treat HSV keratitis. Is that true?
The question is, there's no benefit to use both?
Yes, using oral and a topical. I think it means simultaneously.
Yeah.
And I think we can refer to the head study on that one.
Yeah, I mean, I find that they're both beneficial, especially if you're going to go have something centrally active, centrally located. So if someone had something centrally located, I'd go topical, but then I would add the oral. But where were you going with the herpetic eye disease, Joe?
I think I agree with what you said when you have a dendritic lesion, but I think maybe the question is referencing what happens when you have a patient who's getting some stromal disease, and maybe you put them on steroids and you have them on a topical. Does an oral help? And I think the head study was pretty definitive, showing that it didn't help if you're already on topical. But that was for stromal disease on steroids and a topical. And the topical at that point was Veroptic as well, to remember.
And, the key to, we always say the crime must fit the punishment is that if it's epithelial, it's infectious. If it's in the stroma, I agree, orals aren't going to help because it doesn't really fit the crime doesn't fit the punishment. Once it's in the stroma, it's more of an inflammatory effect. So,
And
an
in that case,
anti-infective. So
yeah,
go
in
ahead.
that case, the topical or oral is only prophylactic to prevent a dendritic outbreak when you're using steroids.
Great. And I'll stop sharing. The majority of the audience here, 66% like Valtrex, and I think we've all migrated to that. And there might be a few reasons that if I can get there, we'll talk about. So let's go through these really quick here. Acyclovir, good for Simplex and Zoster. Typically, it's 800 milligrams 5 times a day, but there is IV in 400 and 200. 500 milligrams 5 times a day. They're big horse pills because poor GI absorption. You just got to take a lot to force it through. And if you're going to go maintenance, the herpetic eye disease study said 400 milligrams twice a day. You could get down to 200 milligrams twice a day on patients also. But again, you're going to see this all the time. Caution if the patient has renal function, they're excreted by the kidneys, and category B. Joe kind of alluded to this a little bit earlier about off-label use. When you talk about Valtrex and Famvir, they're basically off-label use because they're approved for genital herpes. You're not going to find a dosage out there in the PDR. You're not going to be able to call up the drug rep and find out because that would be off-label, and they're not allowed to talk about off-label. So it's through, Joe was mentioning, 9 out of 10 corneal specialists or 3 out of 4 corneal specialists are using Valtrex or Famvir to treat these. Now it becomes, accepted or the standard of care. So it's not bad to go off label. So you could use these medications like Famvir. They're available 125, 250, and 500. If you're going to use Zoster, you would do 500 milligrams 3 times a day. Recurrent herpes, you could do again 500 milligrams once a day or 250 twice a day, or recurrent simplex. Again, caution if they're, if you're using these, they're cleared through the kidneys. Safe to use in pregnancy. All of them are because they're category B. The branded is no longer available. That's not such a biggie because the generics work well. So you can get generic Famvir. And this is nothing more than a prodrug, Valtrex, as you can tell by the name, Valacyclovir. It's a prodrug of acyclovir. It's available in 500 and 1,000. And they all create a little bit of GI upset, and you'll see that as we get to the next few slides. It's good for herpes simplex 1, 2, and zoster. Dosage is pretty much the same for me. We answered that a little bit earlier. We have 1,000 milligrams for a week, 3 times a day. Pretty much simplex or zoster. Again, caution in the kidney failure patients or renal failure or function, and it's safe in pregnancy because of the category B. So here we are, we're back to that patient, that 37-year-old female. This is her 4th episode. We're going to use Zirgan. Remember, Zirgan and Veroptic are category C on there. So, maybe that's where we maybe just use topicals since she's 2 months, or I'm sorry, oral since she's 2 months pregnant. We're going to add that steroid when we get reversal, because then it's going to be pulled into the stroma. When it's pulled in, it creates that inflammatory reaction. And then maybe since it's recurrent, you would consider maybe something like Lysine to help support that immune system. Now, beside dosing frequency, what's the difference between the oral antivirals? And if you just go back to looking at the herpetic eye disease study group, acyclovir for prevention of recurrent disease, the main reason they discontinued was GI side effects. So that was the number one reason why patients left the study. And when you look at the package inserts of these and you see what's in them, right here, you see lactose in acyclovir and you see lactose in Famvir, and there's a lot of patients that are lactose intolerant. So this is just another reason why I like using Valtrex and the generics. All of them are lactose free. So if you have someone that is has that's sensitive to lactose, another reason why to go with Valtrex. How about CNS agitation? This is more or less kind of like along the signs of Charles-Bonnet syndrome, CNS effects in the elderly, agitations, hallucinations. I actually had a patient that was doing this. She got transferred to the area. She was using 1,000 milligrams of 1,000 milligrams of Valtrex 3 times a day. She couldn't weigh any more than 80 pounds. But she had bilateral corneal transplants. And so she was kind of having these hallucinations and agitations, and we slowly backed her down, got her down to 1,000 milligrams once a day, and the CNS effects helped. But Famvir is the most, she's still on her Valtrex in my patient, but consider Famvir or Famciclovir because it has the least effect over acyclovir or Valtrex when it comes to those CNS effects. We talked about this earlier. Is there a difference between topical and orals in the variation forms of ocular herpes? We're talking the infectious part of this. And there were studies out there, oral acyclovir in herpes simplex dendritic ulceration, and just using orals and no topicals. And there was no statistically significant difference in time of resolution, whether you used orals or topicals. Again, my clinical pearl is, since it's the leading cause of corneal vision loss, I just don't like leaving that central cornea, if the central cornea doing nothing. Maybe there's a lot of docs out there that are a lot more comfortable. Again, there's no, I believe, right or wrong, because the studies here are showing that oral acyclovir alone is effective as topical therapy when you're treating simplex. Zoster might be a little bit different of an animal. Remember, Zoster is a little bit more robust between simplex and Zoster. Simplex is wimpy, Zoster a little bit more robust of a virus. You'll see some patients come in and they'll want some natural alternatives out there. And L-lysine is an essential amino acid. It is necessary for human health. The body doesn't manufacture it. It's not endogenous. We have to take it in through food that we eat or get it through supplements. So there you could, send the patient to your local pharmacy and they can get lysine or L-lysine if they want to try something natural for the patient. But basically, some studies have found that taking it on a regular basis helps prevent the outbreaks. From what I found in the literature is this right here. It typically comes in 500 milligrams. While they're active or infectious, you want to give about 2,000 to 3,000 milligrams a day. And then if you're going to go maintenance on them, then you want to do 1,000 milligrams of the L-lysine and to see if that helps them out. Maybe they're just not eating right, or they're on, some type of diet that doesn't allow them to, or they're not eating and getting lysine or L-lysine. So this is a way to support it if they're looking for a natural way. So the cranium keeper here is that when it comes to percentages, patient comes in for the first time, 25% chance of this coming back. It's 43% chance if it comes back again within that year, and then 41% chance of using a maintenance of decreasing it coming back. We talked about the vaccines. I usually lecture with Dr. Offerdahl with this. Tracy, she's a pharmacist. She basically just says, Zostavax is not even used anymore. Pretty much everyone just wants to use Shingrix based on the fact that 90% of it is effective as opposed to about 50%. So it's just more effective. It's a different type. This is an attenuated virus. This is a different mechanism. I forget. It's a recumbent vaccine. There it is right there. And as opposed to an attenuated virus that's out there. And you could see plenty of studies out there, 30 to 70%, 60%. And then when you get to here, you're getting to the 90% of prevention through the vaccine. So when it comes to serious complications, you have neurotrophic states, you have acute retinal necrosis, and we have post-herpetic neuralgia that's out there. So let me just talk real quick on post-herpetic neuralgia. The difference with post-herpetic neuralgia is that it's neuropathic pain. Remember, they live in the neurons. This isn't like, hit your finger with a hammer. Let me take some ibuprofen, take some acetaminophen, or let me take like a Lortab because of the pain. Neuropathic pain does not respond to that type of analgesic. it's a little bit trickier of the two. Neuropathic pain still has this unclear mechanism that's out there, but patients that were on other medications have found that their neuropathic pain has improved. And that's why you'll see kind of that, if you want to say off-label use, or maybe it is approved in some situations of using anticonvulsant medications like Neurontin or Lyrica that have helped patients with their neuropathic pain. Patients taking amitriptyline or medications similar in this category have improved their neuropathic pain that's out there, along with lidocaine patches. You know, this is not a fun pain to have, but there are some options out there when it comes to treatment. So this happened to me quite a few years back, and I didn't know the answer, but a patient came in and they had the Zoster, but they were having the post-herpetic pain, kind of like a trigeminal neuralgia. And, I said to him, look, Lyrica, Neurontin has been used. They were like, wow, man, I had this 3 years ago. Can I take it? Oh, that's a great question. Here was a study right here that says, I guess my family's going crazy in there because of the Steeler game, but does the duration of the neuropathic pain and the effectiveness of would that be affected the length? And what's showing here is that it doesn't really matter. It says right here that if you use something like Lyrica, significant improvement in pain, irrespective of length and time of onset of the neuropathic pain. So the patient was 3 years out. I sent them to their PCP because in Pennsylvania, I can't prescribe it. And the patient actually did fairly well, didn't eradicate their pain, but it made their life more tolerable and able to go on. So that was a good little experience that I had. They're always trying to do different things for neuropathic pain. Here's pulsed radio frequency that's out there that's being looked at. And there's, application of low level lasers. So, it's what we try to do is get these patients diagnosed early, try to get them treated, and that helps minimize the post-herpetic neuralgia. But some patients just get it, and then we just have to try and work with them in many ways that's out there. And again, you can see here, there's lots of treatments, topical capsaicin, there's analgesics that work like lidocaine patches. And again, we talked about the different medications. There's even nerve block and acupuncture for those patients. So neurotrophic cornea ulcer, this has really was a pain to treat until Oxidate came out, which is nice. It's difficult to manage because you get decreased corneal innervation, you get decreased tear production. Medications to avoid at that point would be topical steroids because it increases the collagenase, and collagenase enzyme breaks down collagen. So that would promote some stromal melting. So in a neurotrophic keratitis, we want to make sure that we're not using steroids. NSAIDs really had no benefit, and it did decrease the cornea sensitivity. So the alternatives at that time, we had scleral lenses. We talked about amniotic membrane. Joe was talking about autologous blood serum, which is Vital Tears now. I use a lot of Vital Tears. And at that time, we could also use doxycycline. Doxycycline is an anti-infective. It also, we use it for meibomian gland dysfunction, but it also stops down the breakdown of collagen by inhibiting the collagenase. So we could use doxycycline, we could use Vital Tears, scleral lenses, amniotic membranes, stop things like timolol and NSAIDs. Don't use steroids. These are all things if someone's having neurotrophic corneal ulcer that's on their eye. So, which biologic is indicated for the treatment? Joe, we're just going to skip that in the sense of time. I think most people would answer Oxidate since we brought that up.
And we do have a number of questions. So if we can leave a minute or two at the end, that'd be great.
Okay, let me just let me hit these hard, and then we'll do the questions. I'll go through quickly. So Oxidate is approved in 2018 by Dompe Pharmacy. Pharmaceutica. That's not spelled wrong. It's an Italian-based company. And I think a lot of us have heard of it. So I'll go through a lot of the slides here quickly. It's, the question I had is, which living organism is used to produce oxidate? Was it E. coli, a Chinese hamster ovary, COVID-19, Staphylococcus aureus? Remember, this is a biologic, and these are very complex, complicated medications. It's like a bicycle to a jet airplane. Aspirin would be the bike. Biologics are very complicated. And the answer is they use E. coli to produce this. They put the DNA, they found the DNA sequence of nerve growth factor, and they plug it into the E. coli, and it just lets it keep replicating, and then they twist it up. So what we're trying to do here is corneal homeostasis through the corneal nerve, tear secretion, and epithelial cells. Like this all works through these neurotrophins and neuropeptides. So what we're trying to do is get that corneal nerve back working again and getting the cornea homeostasis repaired. And you can see here how these nerves innervate. And if we get the nerves that are, in a sense, not sensitive, because of what we were showing with the cornea sensitivity, you get loss of cornea sensitivity, you get the breakdown of the homeostasis. And that's what's showing here, impaired trigeminal nerve innervation. Multiple times that virus coming through, it just kind of deadens that nerve. And then you get the impaired trophic supply, you get epithelial alterations, impaired corneal healing. Over here, you're getting impaired trigeminal reflexes, and then you end up with a neurotrophic keratitis. There's lots of etiologies associated with neurotrophic keratitis. Tonight, the one I was focusing on was herpes simplex, but you can see there's a whole laundry list of ocular and central nervous system, systemic. Remember, diabetes, we always think of the retinopathy, but it's a neuropathy, and it can numb the front surface of the eye, and some patients can end up with some keratitis. And don't forget the neuropathy side of this organ, the eye, when it comes to diabetes. You can grade neurotrophic keratitis in different stages. It's that SPK type, and then it starts to become more coalesced, and then you start getting the ulcer formation where the cornea starts to thin, kind of the Mackey classification, stage 1, 2, and 3. You can assess the cornea sensitivity. We showed that tonight through that cornea sensitivity. I'm not going to play the video again. Maybe it's going to try and start, but I'm going to show it. And what they found is using endogenous, or what they found is endogenous growth factor is super, super important in maintaining the cornea integrity. So what they were able to do is make a biologic, and that's what Oxidate is that it's a biologic of nerve growth factor that they were able to make as Centergermin that's out there. So it comes in this percentage of 0.002%. You get 7 vial adapters, 42 pipettes, 42 sterile disinfectant wipes. And I can tell you, this works really, really awesome. I have probably an N of 10 right now. So this is what's really cool about this biologic. Here is endogenous nerve growth factor, and then this is Centergermin. And I like this animation because it just shows you how they made it exactly the same. They make it into a bottle. It's the only biologic that I know, because the molecules are so big, they have to be infused. This is the only one that I know that is in an eye drop form because you're applying it to the organ. You do every 2 hours, 6 times a day for 8 weeks. I'm going to play, well, basically I was going to play this video, but Joe said there's a lot of questions. What I wanted to play is this video right here where the lady is talking about how her eye is feeling better, but yet it hurts. Remember, there's different pain, like you cross your leg and your leg falls asleep, you uncross your leg and your leg hurts. But there's different types of pain receptors that are out there. So when she goes through, she's talking about, man, my eye feels a heck of a lot better, but I have pain in it. It's because it's kind of waking up. So just be careful with that. because it does say on the package insert
All right,
that
here we are with
that pain is one of the number one side effects, but it's a good pain if that makes sense. When you look at the patients from the study at a year out, 80% were still healed. So it's, in a sense, it's getting to the root cause of this. Again, Oxidate was approved in 2018, and I would encourage you to use it on your neurotrophic patients. We talked about sutureless amniotic membranes enough tonight. Just use whichever one you feel. In an infectious keratitis, I would consider Cryo Preserve. That's out there. And here's a nice case where I used one. You can see this big old defect on the eye. You can see it here. And before Oxidate was out, we were able to close that wound. I would probably even consider putting Oxidate on here to really bring back that cornea sensitivity to the patient. So the last thing I'll just kind of remind everyone is that you can get a vitritis and retinitis with these cases. You can get acute retinal necrosis, and that can really be devastating to the eye. It typically starts out here in the periphery, and then you have progressive outer retinal necrosis starting in the posterior pole and working its way out into the far periphery. That's out there. So the treatment with that is documented here. It's in your handout. I'm just going to get quickly through is that anytime you have those kind of acute retinal necrosis, it could be from the herpes viruses, but it could also be from this laundry list of conditions here. So I am going to launch this poll, which will allow me to then, Joe, if you want to do a few questions, and then we can wrap up at a decent time.
Yeah, I'm going to go backwards because of the topic that was just touched upon. Is it difficult to get insurance to pay for Oxidate? Have you found Oxidate to be worth the expense versus other treatments?
Yeah, so I guess the key to jump out real quick is that I think if we all saw how much Oxidate is, I think it's I think I've heard it's $80,000 to $90,000. I haven't had a patient pay $80,000 or $90,000 for it. The nice thing that they knew when they were developing this and it was coming close to being FDA approved, Dompe formed some foundations. So they go through the insurance company to see if it's covered, and then they have a few foundations. They have this thing, I think it's called Dompe Connect. Basically, you prescribe it, you start the process, and then they take over and do a lot of work. So have I found it successful? I wish I would have played the video. I have an N of, like I said, 9 or 10 people that I used it on, and they really, really like me as a doc for recommending it.
It takes a lot for me to pull the trigger on it, but when necessary, we'll do it. My recommendation is meet your Dompe rep, attend a webinar by Dompe, meet them at an exhibit hall, and we have them at our exhibit halls often, and you'll find that they will walk you through it. And once you start the process, they will work with you and the patient to make it as easy as possible. Okay, anybody try acyclovir ointment for skin lesions on the lid or around the eye? I think that putting it in the eye is a little bit risky. It's a dermatologic preparation. I think you can cause some harm, although acyclovir ointment has been approved for ocular herpes in Europe for a long time.
I have not used topical acyclovir.
What is the drug category as relates to steroids as relates to pregnancy?
Well, I'd probably say they're category C.
Yeah. Lysine does help with healing of mouth ulcers too. And another comment or question, Lysine for Zoster as well as Simplex?
Yeah, the answer would be yes. Lysine is nothing more than trying to bolster the immune system. So if a patient is getting Simplex or Zoster, you can certainly, it's not going to hurt them by taking it. The whole idea is if they're low on the Lysine, it can help bolster their immune system and then hopefully decrease the amount of reoccurrence.
Is post-herpetic pain exclusive to Zoster?
I'm going to say no to that.
What would be the best treatment for HSV blepharitis?
Say that again. What's the question?
What is the best treatment for HSV blepharitis? I
The
think you
best
may wanna-
treatment for HSV Blepharae should just be orals. I do orals, and I go full strength. If it's an adult, or even and an adult would be any child that's gone through puberty, and that would be 1,000 milligrams 3 times a day.
My understanding that HSV bleph doesn't respond to anything, but when you see it, it's hard to not do something. So I do prescribe it as well. But there's no control studies that show it's actually beneficial in HSV bleph, especially in kids. I think the last, no, maybe not the last one. When in the disease does ARN or porn present?
Joe, you could probably speak on that because that's more or less the HIV population. And I know you speak in the HIV arena.
And the answer is it's not a continuum. ARN or porn can present often in immunosuppressed patients as the primary disease, and we just have to recognize what the underlying cause is. But a person who has simplex or zoster is not going to necessarily progress from epitheliopathy to uveitis to ARN or porn. It's not a progressive type of thing.
All right. I wanted to do something here. So
A question, any recommendation for a good OD or MD in the North Carolina area to manage an HSV case? I would recommend James Fanelli and or Eric Schmidt.
I just want to see if I go back here, if I'm not sure if I lost the sound. I'm not sure where I am now. Just clicking away. Forward, 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 forward. One more. Keep going.
And how do you manage a pregnant patient who has sterile keratitis? Well, I would do that with their obstetrician, but they're going to need steroids. And probably topical steroids would be best, and try to avoid oral steroids. But in a situation like that, you have to benefit the risk, look at the risk benefit ratio and co-manage with the obstetrician.
And I would probably use something like a loteprednol product on that because it's going to break down by by the enzymes. It's not going to penetrate as much as a ketone would. Let me see if this plays, Joe. Let me just play this real quick. Let me see if you can hear it.
Here we are with our.
Is it playing through on your end?
With our patient, we
Yeah.
have time 0 up here, and then we have a week after Oxidate, and then 2 weeks, and you can see we had a nice improvement today with the SPK with Oxidate. So let's swing over here to our patient. And how's there any difference between last week and this week, or since we started?
The biggest difference is I can now read. Any time of the day I would choose. I can see clearly, and it's a big improvement. And my eyes feel good.
The eyes feel good.
Yes.
It was, so other than that, you said there's really been just status quo since last week.
Yes,
is that correct?
the still a little bit of discomfort, nothing bad.
Good.
And I'm very happy with it.
Good. And this is week 3 of 8, so we'll keep checking in. Thank you very much.
So it's a pretty cool medication. I would encourage you out there. I know the cost is a barrier, but they have great foundations setting up. So what I would recommend is, trying it on a patient that's appropriate, and I think you'll have a great outcome. Any other questions, Joe?
No, I think it's time for us to land this. We're really at 9 o'clock at this point.
Okay. So I just want to say thank you, everyone. This will end the education, herpes, ocular pharmacology, and pearls for the eye. This was an interactive distance learning course. Thank you very much for taking the course.